increase insulin secretion. 4. Autonomic nervous system, particularly parasympathetic nervous system acetylcholine can increase insulin. What about sympathetic, sir? It is only the beta receptor action. Alpha receptor action is different. We are not discussing that here. Beta sympathetic stimulation increases insulin secretion. Now, few GI hormones I mentioned here: gastrin, cholecystokinin, secretin. They all can increase insulin. We are discussing the factors that increase insulin. Now, in this concept, they can ask for picture MCQ. What is that, sir? So the insulin secretion is more for oral glucose. When compared to intravenous glucose, insulin price is actually more for oral glucose. What is this effect, sir? It can be oral glucose elicits higher insulin secretion than intravenous glucose. This effect is called incretin effect. Physiology and pharmacology. Incretins increases insulin secretion. What are those incretin hormones, sir? They are again coming from the GI tract. First one is glucagon-like peptide. Second one is glucose-dependent insulinotropic peptide. So this GLP-1 and the GIP are called as incretins. Incretins are known to increase insulin secretion. So remember this concept: incretins, GLP-1 and GIP. Now, next concept: which factors decrease insulin secretion? Universal inhibitor coming from the D cell somatostatin. Now, certain toxins like streptozotocin, alaxon, they can destroy pancreatic beta cells, toxins, leading to decrease in insulin. And now sympathetic. It is the alpha. Alpha action increases insulin. Sympathetic beta increases insulin secretion. Sympathetic alpha decreases insulin. So it is the alpha mediated decrease in insulin for sympathetic. Now, insulin is the major anabolic hormone. How to remember, sir? Insulin is the hormone of insurance. It is safety. It thinks about the future. It always knows everything. Insulin is the major anabolic hormone. It is the hormone of insurance. Which pathways are stimulated by insulin, sir? Which pathways are inhibited by insulin, sir? First, this side, stimulated. It stimulates glucose metabolism, so that processes glycolysis. It stimulates storage of glucose. We call that as glycogenesis. It also stimulates lipid storage. We call that as lipogenesis. They are all stimulated. Glucose metabolism. Remaining glucose is stored. Lipid is stored. Pathways inhibited by insulin. Those pathways that rises blood glucose will be inhibited by insulin. What is that, sir? Remember, glycogenolysis. Inhibiting formation of glucose from non-carbohydrate sources. What is that? Neoglucogenesis. Inhibiting lipolysis. Very important. So in formation of glucose from non-carbohydrate sources. What is that? Neoglucogenesis. Inhibiting lipolysis. Very important. So inhibiting glycogenolysis, blood glucose will not rise. Inhibiting neoglucogenesis, blood glucose will not rise. It also inhibits lipolysis. So which pathways are stimulated? Which pathways are inhibited? Now finally, we discussed a lot about insulin, a concept for glucose homeostasis. Only one hormone decreases glucose, that is insulin. Decrease in blood glucose, it is always insulin. Hypoglycemia, decrease in glucose by insulin. Its action is balanced by or counteracted by certain counter-regulatory hormones. These counter-regulatory hormones are hyperglycemic. Their action always increases blood glucose. Most prominent names: cortisol, growth hormone, rise blood glucose; glucagon, rise blood glucose; epinephrine, rise blood glucose; thyroid hormones, rise blood glucose. So this is the homeostasis. Decrease by insulin, increase in glucose by lot of hormones. We named them: cortisol, growth hormone, glucagon, epinephrine, thyroid hormone. They are all hyperglycemic hormones. Alright guys, the next endocrine gland we are going to revise is adrenal gland. This picture is a recent image-based MCQ, picture-based question. See, adrenal gland contains adrenal cortex and adrenal medulla. So in cortex we have zona glomerulosa, zona fasciculata, zona reticularis. They are all adrenal cortical things. We also have adrenal medulla. So what comes from glomerulosa, what comes from fasciculata, what comes from reticularis? We need to remember. First, adrenal cortex, zona glomerulosa, mainly the medullalocorticoid aldosterone. Not Glomerulosa is the layer. Formation of new cortical cells. They help in regeneration or formation of new cortical cells. Which layer? Glomerulosa. Fasciculator, which is actually having the maximum population. Fasciculator, 50% you can see. Is for glucocorticoids, our very well known cortisol. Zona fasciculator. Zona reticularis, adrenal sextiloids. This is about cortex. What about medulla, sir? Which is the major catecholamine coming from medulla? It is epinephrine. Adrenal medulla, 90% epinephrine. Only 10% norepinephrine.
Zona millimeter is some mineral corticoid. 10% second aldosterone formation in corticoid. Zona fascicular. GFR glomerulus fascicular reticularis. GFR glomerulus fascicular reticularis. 18 medulla secretes catecholamines. 90% epinephrine secrete करे आणि 10% नो epinephrine secrete करे. Okay, adrenal gland, zona glomerulus, zona fascicular, zona reticularis, adrenal medulla. Zona glomerulus, medulloccorticoid secretes aldosterone, zona fascicular, the glucocorticoid secretes cortisol, zona reticularis secretes the sexterols. Adrenal medulla secretes the catecholamine, 90% is epinephrine, 10% is the norepinephrine. Okay.
So the layers and the hormones coming from here is very, very important. Let's see these hormones one by one. First is aldosterone. It is a steroid hormone. Remember that. It is a steroid hormone. Next, actions of aldosterone. There are two reabsorption, two excretion. We know sodium will be reabsorbed along with it. Water will be reabsorbed.
Sodium, water reabsorption, aldosterone. Yes,
Potassium will be thrown out. H plus ions will be thrown out. Next important concept. These actions depends on two important cells, which are obviously our principal cells and intercalated cells.
Intercalated principle, yes.
The name of the receptor is mineralocorticoid receptor. It is M or aldosterone receptor is mineralocorticoid receptor. There are four stimulants here: sodium, water, potassium, H plus ions.
Aldosterone हुन्छ तपाईको hyperkalemia major stimulus for the release of aldosterone. Hyperkalemia થાય કે વધી જાય. aldosterone નું કામ શું છે કે કાઢવાનું, તો કે વધી જાય તો એ કાઢવા માટે aldosterone આવશે. બરાબર, કે પ્લસ વધે તો કાઢવા aldosterone આવશે. aldosterone receptor છે mineralocorticoid receptor. inactive mineralocorticoid receptor છે પછી active.
The major regulating factor it is always potassium. Remember,
potassium is the major regulating
whenever
factor.
there is
Yes.
hyperkalemia, that means elevated levels of potassium. Hyperkalemia is the major stimulus, major regulating factor for aldosterone. Now, how all this function happens, we will see. Actions of aldosterone. For sodium reabsorption, we have epithelial sodium channel. Wherever sodium goes, water follows. Water reabsorption. What about potassium, sir? We have renal outer medullary potassium channel. This is what? Potassium excretion. So whatever sodium comes inside will be taken into blood with the help of sodium potassium ATP. So what we have seen? Sodium reabsorption, water reabsorption, potassium excretion. All this happens in principal cells.
Principal cell, okay. Principal cells है active section inactive. सोडियम वाटर अंदर, पोटेशियम आउट रोम्ब थी. ROM के प्लस आउट, Na प्लस H2O इन थी. बराबर, ओके.
What about H plus ion excretion, sir? It happens through intercalated cell. So H plus ion excretion happens through intercalated cell. Now the clinical significance. Those epithelial sodium channels are actually blocked by this important group of agents, amyloride. By blocking epithelial sodium channels, sodium is not reabsorbed, leading to sodium excretion. Very important. Epithelial sodium channel blockers are amyloride. What happens whenever there is overactivity of epithelial sodium channel? We have a very important syndrome that is called Liddle syndrome. Gain of function mutation of epithelial sodium channel. The patient will present with elevated blood pressure. Commonest presenting feature is hypertension. Liddle syndrome, gain of function mutation, epithelial sodium channels, high blood pressure, hypertension. Liddle syndrome, hypertension. Now, next. One important clinical finding. We just have to think clearly on this aspect. Look here. In spite of increase in extracellular fluid volume, edema does not develop in hyperaldosteronism. In
spite of increase in extracellular fluid volume, in spite of increase in edema does not develop. No. In spite of increase in extracellular fluid volume, edema doesn't develop in hyperaldosteronism because what? I don't know.
For aldosteronism, more sodium will be absorbed, more water will be absorbed, but still there is no edema. What is the reason? Because kidney escapes the action of aldosterone. What we call this phenomenon, aldosterone escape.
किडनी होकर
For aldosteronism, more sodium will be absorbed, more water will be absorbed, but still there is no edema. What is the reason? Because kidney escapes the action of aldosterone. What we call this phenomenon, aldosterone escape. Because this elevated level of sodium is going to induce pressure diuresis. So sodium will be excreted, water will be excreted. But most importantly, one more reason for the sodium excretion is natriuresis. So sodium is not
sodium
no
with
edema because atrial natriuretic peptide is excreting those sodium. Even though aldosterone is there, sodium is getting excreted. That means kidney is escaping the actions of aldosterone.
sodium bartaturia
Predominantly because of atrial natriuretic peptide. Why in hyperaldosteronism there is no edema? Because of pressure diuresis, because of atrial natriuretic peptide causing natriuresis. This phenomenon is aldosterone escape. Right. From aldosterone, let's shift our attention to cortisol. What cortisol does in carbohydrate metabolism? It increases blood glucose level. Now we have recently discussed it is always considered to be hyperglycemic. Protein metabolism, you have to be careful. From the muscle, there is proteolysis. So hypercortisolism, muscle weakness will be there because of proteolysis.
action of cortisol action શું છે ઇફેક્ટ ઓન કાર્બોહાઈડ્રેટ મેટાબોલિઝમ કોર્ટિઝોલ સ્ટ્રેસ વધારે ગ્લુકોઝ સ્ટ્રેસ લખ્યું છે સ્ટ્રેસમાં કાર્બોહાઈડ્રેટ વધી જાય વધારે સ્ટ્રેસ વધારે ગ્લુકોઝ પ્રોટીનમાં કેટાબોલિક ઇન મસલ પ્રોટીઓલાઇસિસ વધારે સ્ટ્રેસ પાતળા થાય પણ ગ્લુકોઝ વધારે ઊંચાડા થાય લિપિડાઈ તૂટે ઇમ્યુન સિસ્ટમ એન્ટી ઇન્ફ્લામેટરી એજન્ટ છે કોર્ટિઝોલ ઇન્ફેક્શન હોય તો ન દેખાય બ્લડ સેલમાં કોર્ટિઝોલ ડિક્રીઝ ધ બ્લડ લેવલ ઓફ ઇઓસિનોફિલ લિમ્ફોસાઇટ ન્યુટ્રોપ્લેટલેટ આરબીસીનું ઇન્ક્રીઝ કરી નાખે નર્વસ સિસ્ટમમાં અલ્ટર મૂડ એન્ડ બિહેવિયર ભૂખ વધારે ભૂખ લાગે કિડનીમાં ગ્લોમેરુલર ફિલ્ટ્રેશન રેટ વધારે કેલ્શિયમ એક્સક્રીટ કરાવે બોનની અંદર બોન રિઝોર્પ્શન કરાવે 1 મિનિટ કાર્બોહાઈડ્રેટ તોડે કાર્બોહાઈડ્રેટ વધારે ફેટ તોડે પ્રોટીન તોડે મસલનું પ્રોટીન તોડે ઇમ્યુન સિસ્ટમ સારી કરે એન્ટી ઇન્ફ્લામેટરી ઇમ્યુન સિસ્ટમ બ્લડ સેલ ન્યુટ્રો ઇયોસિનો ન્યુટ્રો આરબીસી અને લિમ્ફોસાઇટ અને ઇયોસિનોફિલ ઘટાડે ન્યુટ્રો આરબીસી અને પ્લેટલેટ વધારે નર્વસ સિસ્ટમમાં શું ઇફેક્ટ છે નર્વસ સિસ્ટમમાં અલ્ટર્ડ મૂડ કરી નાખે અને એપેટાઇટ વધારે કિડનીની અંદર ગ્લોમેરુલર જીએફઆર વધી જાય અને કેલ્શિયમનું એક્સક્રીશન થવા માંડે કેલ્શિયમનું એક્સક્રીશન થઈ જાય હાઇપોકેલ્શિયમિક ટીટીની ખબર નહીં કનેક્ટિવ બોનની અંદર બોન રિઝોર્પ્શન વધારે ફ્રેક્ચર થઈ શકે increase activity of osteoclast connective tissue inhibit fiber delay wound healing purple stripe on skin GIT માં ગેસ્ટ્રિક એસિડ વધારે પેપ્ટિક અલ્સર કરાવે રિપ્રોડક્શનમાં GnRH ને ઇનિબિટ કરે અને એમિનોરિયા લોસ ઓફ લિબિડો GnRH ઇનિબિટ કરી નાખે એમિનોરિયા લોસ ઓફ લિબિડો ઇન્ફર્ટિલિટી ગેસ્ટ્રિક એસિડ પેપ્ટિક અલ્સર કરાવે જો ભૂખ લાગે તો એસિડ વધે તો પેપ્ટિક અલ્સર થાય ઓકે
system, perhaps this action of cortisol actually got the highest award for a Dr. Nobel Prize. Remember, cortisol is always considered to be anti-inflammatory. Cortisol, pharmacology used in treatments, it is an anti-inflammatory agent. Now, in blood cells, cortisol decreases the level of eosinophils. Most importantly, eosinophil levels decrease, lymphocytes level decrease. So cortisol decreases the blood levels of eosinophils and lymphocytes, but increases the blood level of RBC. It increases the blood level of neutrophils. It increases the blood level of platelets. Very important. It decreases allergy causing eosinophils. It decreases lymphocytes, but increases RBC, increases neutrophils, increases platelets. Neural action, it alters mood and behavior. It also increases appetite. What about kidney, sir? Cortisol increases glomerular filtration rate. It also increases calcium excretion. Very important. It increases GFR. It also increases calcium excretion. Other actions of cortisol on bone. Remember, steroid usage, excessive steroid usage, bone fractures can happen. Why? It stimulates bone resorption. It stimulates bone resorption by activating osteoclasts. Very important. Cortisol on bone. It stimulates bone resorption. That is why excess cortisol, bone fractures are common. By stimulating osteoclast. On connective tissue, you see in Cushing syndrome, a classical purple stripe. Why? High levels of cortisol inhibit fibroblast proliferation and collagen formation. There will be delay in wound healing. They will have purple striae because cortisol inhibits fibroblast proliferation and collagen formation. GIT, it increases gastric acid. Remember, very important. So peptic ulcers are very common. GIT, it increases gastric acid production. Reproduction, cortisol inhibits gonadotropin releasing hormone. Cortisol inhibits gonadotropin releasing hormone. That is why excess levels of cortisol. There will be amenorrhea. There will be loss of libido. Infertility is very, very common. Cortisol inhibits gonadotropin releasing hormone. So the effects are amenorrhea, loss of libido, infertility. And next, few points are adrenal sex steroids. What is the first point you need to remember here, sir? This is the source of sex hormone, not only in male, it is also the major source of male sex hormone in female. Female also have adrenal sex steroids, right? So this adrenal sex steroids are found both in male and female. Now what are those sex steroids? Dehydroepiandrosterone, the major one. DHEA, found both in male and female. DHEAS, sulfate, androstenedione, testosterone, only small amount but still female it can be found. Adrenal sex steroids, which is the major one, dehydro or dihydro, epiandrosterone. Other ones are epiandrosterone sulfate, androstenedione, and also testosterone. The major adrenal sex steroid is always dihydro, epiandrosterone. Remember this. Alright guys, now we are going to revise calcium homeostasis. Why calcium homeostasis in endocrine physiology? Because levels of calcium are tightly regulated by certain important hormones. We will see them. Homeostasis means how much is the normal serum calcium level we are interested, around 9 to 11 milligram per deciliter. This is the overall levels, 9 to 11 milligram per deciliter. This we can split into two forms. Ionized form, 50%. Protein bound form, close to remaining 50%. This ionized calcium is considered to be the free calcium, which is responsible for all the actions of
normal serum calcium level 9 to 11. Ionized calcium, protein bound calcium. Ionized calcium 50% of total calcium. Normal is also 50% of total. Ionized calcium is in free, it is in storage form. Physiologically active form is ionized calcium, inactive form in pH changes in calcium. Respiratory alkalosis too. Respiratory alkalosis क्या रहता है हाई एल्टीट्यूड में, हाई एल्टीट्यूड तो एच आयन घट से એટલે શું થશે કેલ્શિયમ બાઇન્ડ્સ ટુ ધ આલ્બ્યુમિન. એચ આયન ઘટી જશે, એચ આયન ઘટી ગયા. ઓકે ડન જો આલ્કલોસિસમાં એચ આયન ઘટી જશે અને એચ અને કેલ્શિયમ છે ને કોમ્પીટ કરતા હતા આલ્બ્યુમિનમાં બાઇન્ડ થવા માટે. તો એચ નહીં થાય, કોણ થશે? કેલ્શિયમ થશે. કેલ્શિયમ બાઇન્ડ થશે તો બાઉન્ડ ફોર્મ વધી ગયું, ફ્રી ફોર્મ ઘટી ગયું, હાઇપોકેલ્શિયમિયા થઈ ગયું. હાઇપોકેલ્શિયમને કારણે હાઇપોકેલ્શિયમિક ટીટની થઈ ગઈ. સેમ પાલ. ચલો.
For example, muscle contraction, exocytosis, secondary messenger. All these are because of free calcium, which is also called ionized calcium. The remaining half, protein bound calcium, is considered to be the inactive form. It is mainly for storage. Take home message. Ionized calcium, free calcium, is the most active form. Now, what is going to determine how much of free calcium will be there, how much of bound calcium will be there? Blood pH is going to determine that. Why, sir? What is the reason? A very interesting scenario. There is a common binding protein, albumin, for both H plus ions and calcium. Alkalosis means when there is low H plus ions, the competition is out. Now it is only calcium which can go and bind with this albumin. So what happens to these forms? Calcium bound form will increase, calcium free form will decrease. If calcium free form is decreasing, we call that as hypocalcemia. We call this state as hypocalcemic tetany. So it is the blood pH which is going to determine bound form and the free form. In respiratory alkalosis, free form decreases. No action possible. Hypocalcemic tetany, where will you see in respiratory alkalosis? Now, which factors affect the calcium absorption? It is mainly absorbed from the duodenum. Yes, very good. Absorption of calcium is always facilitated by gastric acid. And also, if you take protein-rich diet, yes, two important factors: gastric acid, protein-rich diet. They all increase or enhance calcium absorption. Which factors inhibit? This is most important. For example, something called as phytates, oxalates. They form complexes. They form insoluble complexes. So calcium is not absorbed that easily. Absorption of calcium is inhibited by substances like phytates and oxalates present in our diet. These phytates and oxalates inhibit calcium absorption. Gastric acid and protein-rich diet enhances calcium absorption from duodenum. Now, neglecting factors. It is about the rule of 3 for calcium homeostasis. 3 major hormones: parathormone, vitamin D, calcitonin. They must act in 3 regions. The bank for calcium storage: bone, from the diet, intestine. Excess calcium is there. You excrete that calcium out into urine, kidney. So 3 hormones, 3 organs. We'll discuss one by one. First, very important, the parathormone. What is the source, sir? It must come from parathyroid gland. From which cells? We call this cells as chief cells, parathormone producing ones. Next, type of hormone. Its structure is a protein hormone. Parathormone. Protein hormone means amino acids. How many amino acids, sir? 84 amino acids. That is why we have a drug form of this parathormone for treatment purposes. What is the name of the drug form, sir?
Teriparatide. Okay.
So parathormone. Important points. Research interest. Now let's move into the actions. 3 organs we are going to consider. First, the most important organ, obviously, it is bone. What is the action in bone, sir? Remember, it stimulates bone resorption. That is the most important action. Parathormone is going to stimulate bone resorption. How is that possible? What is the mechanism? The cell that is concerned with bone resorption is osteoblast. But if they ask you where the parathormone receptors are located, it is located only in the osteoblast. Parathormone receptors are found in osteoblast. Now the parathormone is going to release something called the rank ligand. It is the rank ligand that will stimulate osteoblast, eventually leading to bone resorption. Parathormone receptors are found in blast. What it will release? Rank ligand. Who is stimulating this osteoblast? Rank ligand. Eventually what will happen? Bone resorption. Next, kidney. What is the action here, sir? What is the mechanism here, sir? We have something called as a sodium phosphate cotransporter. Parathormone is going to inhibit this channel. Because of that, it is definitely going to be phosphate excretion. So parathormone is known to decrease phosphate levels because it is causing phosphate excretion by inhibiting sodium phosphate cotransporter, which is found in proximal collitic tubule. Parathormone inhibit sodium phosphate cotransporter, phosphate excretion, reducing phosphate. Because of that, parathormone's other name is phosphatonin. Any hormone that reduces phosphate level, it is a phosphatonin. Phosphatonin in human body is parathormone. It excretes phosphate, leading to low levels of serum phosphate. Now, what is the action in intestine, sir? Parathormone does only one thing. It increases vitamin D levels. That's all. So the action in intestine is indirect. Parathormone is shown to increase vitamin D levels. Rule of thumb: the only hormone that acts in GIT is vitamin D. Parathormone simply increases that vitamin D to produce its action in intestine. Now, what about other 2 hormones, sir? Vitamin D. First, we will see what is the major stimulus. Remember, decrease in calcium, decrease in serum phosphate, increase in parathormone. Because I told you, parathormone is known to stimulate the release of vitamin D. So low calcium levels, low phosphate levels, and increase in parathormone all can release vitamin D.
release hormone તો રહેવું પડશે મારે રીતનું. જાવજી ભાઈ રાગ અંતો નહીં.
In both, D stands for D, that means it is doing. It is going to promote both bone mineralization, very important, bone mineralization and bone resorption. What is the ultimate understanding, sir? Depending on the serum calcium levels, if there is more calcium, deposit that in the bone. If there is less calcium, take that away, bone resorption, that's all. In bone vitamin D, D1, it promotes both mineralization and resorption, depending upon the serum calcium levels. Interesting. It increases both the calcium and phosphate absorption. From the kidney, also it increases both calcium and phosphate reabsorption. So the overall effect is increasing both calcium and phosphate. Parathormone, what we have seen, it can only increase calcium. Parathormone decreases phosphate. But vitamin D never shows that what's helping. Vitamin D is known to increase both calcium and phosphate. Vitamin D is known to increase both serum calcium and phosphate. What about this calcitonin, sir? Increase in serum calcium. Calcitonin by inhibiting bone resorption. That means it is going to inhibit which major cell? It is inhibiting osteoclast. Calcitonin decreases calcium by inhibiting bone resorption, by inhibiting osteoclast. It also inhibits calcium absorption from the GI tract. It increases calcium excretion from the kidney. All these actions finally decreases calcium levels. So calcitonin in intestine inhibits calcium absorption. From the kidney it increases calcium excretion. All the actions finally denote falling serum calcium levels for calcitonin. Most importantly, the overall effect is decreasing serum calcium. So calcitonin decreases serum calcium. So this hormones regulating calcium homeostasis, very, very important. Endocrine physiology, particularly in recent times, as I have seen both in medicine and physiology, so many questions, guys, very high yield. Please revise them. Good luck and best wishes. Welcome back, guys. Now in physiology division, it is about the love for making babies, love for procreation. What is this about? Physiology of reproduction. First, we will discuss about the male reproduction, then we will discuss the female reproduction. First, male sexual development obviously requires the presence of which chromosome? Y chromosome. What is there in Y chromosome? Look into the picture. A very important gene, S or Y gene. Sex determining region in the Y chromosome. S for S, where it is present in the short arm. Okay. The sex determining region, S or Y, this gene is responsible for two important aspects for male development. First, it is going to stimulate the Sertoli cells to produce anti-Mullerian hormone, which is actively going to inhibit female sexual development. Now, for active male development, we have to stimulate the Leydig cells to produce testosterone, the major male sex hormone. So SRY gene does two things. Sertoli cells are stimulated, anti-Mullerian hormone comes, female development is inhibited. Leydig cells are stimulated, testosterone comes, male organs are actively developing. So this is about the presence of Y chromosome and the SRY gene in the short term, Y chromosome. Next important event is about hitting the puberty, where the most important thing, the GnRH neurons. How is their secretion? Before puberty, it is continuous. Remember, this continuous GnRH secretion is actually known to inhibit the release of FSH and LH. Okay? Continuous secretion is not needed because continuously if it is secreted, it inhibits FSH and LH. Before puberty, this gonadotropin releasing hormone, its nature is continuous because of two important neurotransmitters, GABA and melatonin. Reason for this continuous nature, it is not pulsatile because the pulsatile secretion is inhibited by GABA and melatonin. Exactly around the time of puberty, the secretion becomes pulsatile. Very important. This pulsatile secretion of GnRH actually releases follicle stimulating hormone and luteinizing hormone. What is actually happening during puberty? A very important protein whose name is kisspeptin, who is going to act on its receptor, G protein coupled receptor 54, GPR54, G protein coupled receptor 54. These receptors are found in the GnRH neurons.
Kisspeptin, GPR, G protein receptor 54, kisspeptin and E pulsatile.
Acting on this important receptor on the GnRH neurons, now the continuous secretion becomes pulsatile. Under the influence of who? Kisspeptin. Once it is pulsatile, once it becomes pulsatile, that is the point of hitting puberty. Not only sex factors, from the periphery, a permissive signal is needed. Who is that peripheral signal, sir? It is leptin. Puberty will commence only when there is adequate body fat stores. Very good. If the body fat stores are adequate, then puberty can be commenced. How to signal this? Yes, in the periphery, body fat stores are adequate. Who is giving the signal? Leptin. The peripheral signal is leptin. So during puberty, remember kisspeptin that brings the pulsatile nature. Permissive role is by leptin that signals adequate body fat stores. Good. Now, a very important developmental scheme, spermatogenesis. Important diagram. We have the stem cell that is spermatogonium, which undergoes mitosis to form primary spermatocyte. Remember, primary spermatocyte. It is 2N. This primary spermatocyte now undergoes the reduction division, meiosis, reduction division, to form two secondary spermatocytes. This secondary spermatocytes further undergo one more.
स्पर्मेटोगोनियम में माइटोसिस का 72 भाग है, 7 का 8 और एक माइटोसिस खबर नहीं। माइटोसिस में प्राइमरी स्पर्मेटोजोआ meiosis 1 થાય તો 1 and 1 થઈ જાય, સેકન્ડરી સ્पर्मेटोसाइट બની જાય, સ્पर्मेटोसाइट બને, સેકન્ડરી સ્पर्मेटोसाइट બને, meiosis 2 થી સ્पर्मेटिड બને અને ડિફરન્શિએશન થઈ જાય, સ્पर्मेटोगोनियम બને, સ્पर्मेटोजेनेसिस થાય અને ફર્મેશન થાય. Maturation motility ને બી ડેમેજ થાય, maturation and motility ને બી ડેમેજ થાય. કેપેસિટેશન જે છે એ વાત है. Activation of cat's spur. Cat's spur. Calcium channels forward progressive motility from capacitation occurs in female genital tract, increasing forward motility from female protein reaction.
Reduction division to form how many? 4 spermatids. Secondary spermatocyte, second reduction division forms 4 spermatids. These spermatids differentiate to form the mature sperm. The process of forming differentiating spermatid to mature sperm is called spermiogenesis. Once a sperm forms, it has to be released. That release process is called as spermiation. What is this? Release of sperm. You not only have to form the sperm, you have to release it. The release of sperm is called as spermiation. Development from spermatid to mature sperm is called spermiogenesis. Now, few important functional aspects of this sperm. Where the majority of sperm takes place, it takes place in epididymis. Very important location. Sperm acquires the capability of motility in the epididymis. This is called the maturation. Capability of motility. But even more important is the capability of forward motility. For that, it requires the activation of a special calcium channel. We call that calcium channel as cat's spur. It is the calcium channel that is present in sperm. So maturation, capability of motility in epididymis. But for forward motility, sperm have to acquire this calcium channel that is cat's spur. You don't have to confuse this maturation with one more important process, capacitation. Capacitation happens in the female genital tract, remember. Following its release, capacitation happens in the female genital tract. During capacitation, what happens? It is the forward motility. That is very, very important. Remember, it is the forward motility of sperm increases. Thus, the forward motile sperm is always capable of something called as acrosome reaction. This acrosome reaction is the process of releasing enzymes to break open that zona pellucida layer. This acrosome reaction is a prerequisite for successful fertilization. All this happens in capacitation. So it happens in the female genital tract. Forward motility increases. Sperm have to acquire the acrosome reaction to penetrate zona pellucida. Now, we all know, we checked this concept, beautiful concept recently. The only one sperm can penetrate a ovum. There is no possibility of a polyspermy. How is that possible, sir? Look at this beautiful diagram. This is the sperm who is going to win this sperm, and this is the ovum. Yeah. In its cortex, you see certain granules. These granules are called cortical granules. They are enzyme filled. What is the enzymes that they have? They have certain hydrolytic enzymes. They will be released only in the presence of calcium. Whenever calcium level rises, this hydrolytic enzyme will be released from these cortical granules. What they will do? They are going to modify this zona pellucida protein ZP2 to a very thick ZPF. It is going to be very, very thick ZPF. ZP is the zona pellucida protein 2, which is actually modified by this enzymes into ZPF. All this because of cortical granules. We call this as cortical reaction. That is the one which is going to prevent polysperm. Even more beautiful diagram. Now look here. One sperm came, it penetrated, gone inside. The gate is tightly closed. Now, no other sperm can enter. But it becomes now ZPF. Recent most question. To prevent polyspermy, the single most important reaction is cortical reaction, where zona pellucida protein 2 is modified into a thick, tight ZPF. Important. Now, we have a cell, Sertoli cell, which does a lot of functions. What are these functions, sir? In the first slide I told you, remember anti-Mullerian hormone to inhibit the female development. It comes from Sertoli cells. Next, it forms something called as blood-testis barrier, so that no substance can come from outside to destroy our sperm. It's a tight barrier, blood-testis barrier. Not only that, it gives food for the developing sperm. We call that as providing nutrition. Remember, nutrition. Every single step is tightly monitored for development of sperm by Sertoli cells. For this reason, it is called nurse cells, provides adequate nutrition. Next, it produces androgen binding protein. Androgen is produced by Leydig cells. Androgen binding protein is actually produced by Sertoli cells. Next, an important enzyme aromatase, the source is Sertoli cells, and inhibin, which is going to negative feedback regulation of follicle stimulating hormone. This inhibin comes from Sertoli cells. Next, dead sperm. Remember, dead sperm. We will not leave them just like that. They will be phagocytosed by Sertoli cells. All these actions are very, very important. Sertoli cells are our nurse cells for our developing spermatozoa. Now, this sperm is found in the seminal secretion. What is the composition of this semen, sir? The major bulk contribution comes from seminal vesicle.
Secrete anti-Mullerian hormone, act as blood-testis barrier, BTB, nutrition to developing sperm, જે dead થઈ ગયો અને phagocytose કરે, release the androgen binding protein and secrete inhibin which acts as negative feedback on FSH. Then
60% of volume. Next comes from prostate gland. Least minimal contribution from was difference. What all comes from seminal vesicle? Was many times before, guys. The energy source, fructose, seminal vesicles. This substance, phosphatidylcholine, which we actually do a test, forensic medicine, test for seminal stains, Florence test. What we estimate, phosphatidylcholine, which is a constituent of seminal vesicle, antioxidant, ascorbic acid, that is our vitamin C. Prostaglandins, how to remember? Prostaglandins does not come from prostate, it comes from seminal vesicles, right? Seminal vesicle constituents. But about prostate glands, sir, prostate gives spermine. It is actually detected for various tests, again tested for seminal stain, forensic medicine. Fibrinolysin, zinc comes from prostate, and prostatic acid phosphatase.
Barbario.
The major bulk contributor is seminal vesicle. The next one is prostate. Remember, spermine for various test, phosphatidylcholine, Florence test. Now, the proper male sexual act to release the semen outside, the male sexual act, involves first and foremost the erection of penis. What is this erection of penis, sir? It is pointing. Erection means pointing. Very important. Easily remember, this is about the concept of pointing. P for P, parasympathetic nervous system, erection. S2, S3, S4. With the help of acetylcholine pointing, not only this parasympathetic, we have a very special system called non-adrenergic, non-cholinergic. The most important member of this is nitric oxide. So nitric oxide is very important for erection of penis. Remember that. Dilation of arterioles with the help of nitric oxide leading to compression of veins. It is this compression of veins leading to
erection, parasympathetic, S2, S3, S4, neurotransmitter, acetylcholine, non-adrenergic, non-cholinergic system, nitric oxide via GMP, dilatation of arteries, the compression of veins, penile engorgement, okay, phosphodiesterase degrade CGMP, phosphodiesterase PD inhibitor sildenafil will stop degrading CGMP, inhibit CGMP degradation, and phosphodiesterase inhibitor sildenafil, tadalafil.
engorgement of penis or erection of penis. Dilation of arterioles by nitric oxide compresses the outflow. No outflow is possible, compression of veins, engorgement. Now, this nitric oxide acts through cyclic GMP, we all know. But who is this villain here who is going to destroy the cyclic GMP? It is phosphodiesterase. Phosphodiesterase. It is for this reason. If you want to have erection of penis, you need a phosphodiesterase inhibitor. What is that phosphodiesterase inhibitor, sir? Sildenafil. Yes. If you inhibit this phosphodiesterase, cyclic GMP is not degraded. So nitric oxide actions are more pronounced. This is erection of penis. Following erection, the next process is ejaculation. Ejaculation is shooting, the actual process. See, pointing, erection, shooting, ejaculation. Yes for yes, sympathetic root values.
Pointing, parasympathetic. Ejaculation is sympathetic. T12, L2. S2, S3, S4, T12, L1, L2. Shit. Pointing.
Next process is ejaculation. Ejaculation is shooting, the actual process. See, pointing, erection, shooting, ejaculation. Yes for yes, sympathetic
Point.
root values, T12 to L2. Very important. It involves two processes. First is emission, then the ejaculation proper. Following ejaculation, sperm can survive for up to 1 to 2 days. So erection is over, ejaculation is over. This good thing, this beautiful thing must come to an end. What is that? Resolution, which is also called intumescence. Remember, for erection we had dilation of arterioles. If you want resolution, there should be constriction of arterioles, which is actually done by endothelium and norepinephrine. So resolution, constriction of arterioles, the process comes to end with the help of endothelium and norepinephrine. Good. Now, how are we going to regulate this male reproductive function? We have a beautiful concept.
Male reproductive function
What is the
regulation.
simple meaning, sir? The two cells are Leydig cells and Sertoli cells. The two gonadotrophins are luteinizing hormone and follicle stimulating hormone. That's all. From hypothalamus, we have GnRH that will act in anterior pituitary, leading to release of luteinizing hormone and follicle stimulating hormone. Luteinizing hormone, L, acting Leydig cells, releases testosterone. Follicle stimulating hormone, acting Sertoli cells, releases
Luteinizing hormone. Luteinizing hormone, Leydig cell, testosterone. FSH, follicle stimulating hormone, Sertoli cell, inhibin. LLT, FSH. Two cell gonadotrophin model. Two cell, two gonadotrophin model. Sertoli માટે FSH, Leydig માટે luteinizing testosterone. Luteinizing Leydig testosterone. Sertoli cell તો બસ મજા કરાવે છે. Function of testosterone.
It's the negative feedback regulator for follicle
Negative.
stimulating hormone.
Inhibin negative.
Testosterone can only inhibit luteinizing hormone. For follicle stimulating hormone, the negative feedback regulator is always inhibin. This inhibin sources Sertoli cells. Right. Now we are going to understand the functions of the major male sex hormones. Obviously, it is testosterone. What is the role of this testosterone, sir? Stimulation of Wolffian system. Very important. Wolffian stimulation, leading to formation of, remember, always male internal genital organs. This is critical. Testosterone is important for growth of male internal genital organs. Next, it stimulates erythropoid. Thereby, in male, there is increase in RBC. Next, protein anabolic effects. Very good for increase in muscle mass. Remember, increase in muscle mass, protein anabolic. Next, it also stimulates
muscle mass,
bone growth in men.
growth.
Next, initiation and maintenance of the beautiful process of spermatogenesis. testosterone.
Glucogenesis.
Stimulates androgen binding protein. We have discussed already. This androgen binding protein comes from Sertoli cells.
Androgen.
So testosterone stimulates the Sertoli cells to increase the production of its binding protein, androgen binding protein. Behavioral effect means the sexual desire, remember, libido, will be governed by testosterone. So testosterone is for male internal organ development. From testosterone, we get even more potent form, formed from testosterone by the action of the enzyme 5-alpha reductase. With the help of this enzyme, testosterone is converted to dihydrotestosterone. In terms of potency, it is more potent. Very important. 5-alpha reductase converts testosterone to dihydrotestosterone. Its level is especially associated rises around puberty time. Dihydrotestosterone mainly during puberty. Remember guys, masculinization of external genital organs. Testosterone, internal genital organs. Dihydrotestosterone, mainly for external genital organs like penis growth, scrotal growth. It is also important for the development of prostate. Very, very important. Prostate gland means dihydrotestosterone. Now, other than that, growth of facial hair, acne, particularly men tend to have this temporal baldness, temporal recession of hairline. All these are because of dihydrotestosterone. Now we know prostate gland growth is governed by dihydrotestosterone. The enzyme that helps in formation of DHT is 5-alpha reductase. So in cases of benign prostatic hyperplasia, overgrowth, we use which important agent? 5-alpha reductase inhibitor. What is the name of that drug, sir? Finasteride. Now you know the basis, physiological basis, correct? Benign prostatic hyperplasia, we use 5-alpha reductase inhibitor for treatment, and that is finasteride. Remember the actions of testosterone. Don't confuse that with dihydrotestosterone. Alright guys, now let's understand female reproductive physiology. In male we have spermatogenesis. Here in female it is about oogenesis. Now, we have oogonia, the stem cell, which undergoes mitosis to form primary oocyte. This primary oocyte is having a meiosis 1 arrest. That means the reduction division 1 will not happen till puberty. Only at the time of puberty, this reduction continues. So this primary oocyte is under arrest, meiosis 1 arrest till puberty. Hitting puberty, it will commence this reduction division. What it will form? A first polar body and a secondary oocyte. This secondary oocyte will also have an arrest. What is that arrest, sir? Meiosis 2 arrest. The secondary oocyte will not undergo reduction division till fertilization. Only at the time of fertilization, remember, this meiosis 2 commences, leading to formation of a second polar body and a female pronucleus. So meiosis 1 arrest till puberty, meiosis 2 arrest till fertilization. This is about oogenesis. Now, the most important monthly cycle, it is about the menstrual cycle, 28-day cycle. Remember guys, 14th day is considered to be the day of ovulation. Before that we have follicular phase. After that the constant luteal phase. Menstrual cycle is always about the hormonal changes. 4 important hormones we are going to consider. Timeline. Which is the first hormone to rise? Always.
Okay, let's take a break and end this module here.